It is my pleasure to open up this webinar. I'm Radonna Chandler, and I worked at the National Institute on Drug Abuse, the National Institutes of Health, for over 25 years. And I am now a scientific advisor for Addiction Policy Forum, and you are in for a real treat. Today, this webinar is part one of a three-part series on cannabis. Today, we're going to be discussing some of the basics of cannabis use in the United States, of risks and harms. And there's going to be sort of a broad introduction to topics to come, including things about treatment. And then we're going to delve into the ever-evolving regulatory landscape regarding cannabis products and the impact that that is having across the country on things like use and cannabis use disorder. Part two of the series is going to focus on the medical use of cannabis, what we know from a scientific basis and what we don't know of cannabis use disorder. We solicited questions from you all in advance. Thank you very much for those who responded. That's been very helpful. I'm happy to say that a lot of the questions that you submitted are going to be addressed and have been shared with the presenters both today and the presenters that are going to be presenting on the subsequent webinars. So today we're not going to address any questions that have to do with treatment for cannabis use disorder, because those are going to be covered later, or the medical use of cannabis. We're largely going to focus on risks, consequences, the epidemiology, and then the regulatory space. We have two fantastic speakers that I've known for many years that I have the privilege of calling not only colleagues but friends. And I want to introduce you to both of them. First, we have Jess Halsey, who is the Addiction Policy Forum founder and CEO. She has a lifetime of experience, beginning in childhood. Addiction's a very personal issue for her. Both her parents struggled with heroin addiction, which led to homelessness, foster care, and eventually she was raised by her grandparents. Jess's work began in the prevention space when she was a teenager, and then she was eventually appointed by a sitting president to serve on the Drug-Free Communities Commission, serving as a legislative aide to the U.S. House of Representatives and working to pass and fund the Second Chance Act, which helps individuals returning home from prison and jail. In 2015, she founded Addiction Policy Forum, which will celebrate its 10-year anniversary. Congratulations, Jess. That's a big accomplishment. To be able to help families and patients struggling with the disease of addiction. Since then, the organization's mission has continued to grow with a dedicated and talented team to help them to deploy needed programs and resources. And then we also have Rosalie Pakula, who is a PhD in health economics. She is the Elizabeth Garrett Chair in Health Policy, Economics, and Law in the Health Policy and Management Department at USC. She was trained in applied microeconomics, and she has been conducting evaluations of state and public health policies and programs that target risky behaviors for youth, mental health treatment, and substance use disorders for more than 25 years. Much of her published work has focused on the market for legal and illicit addictive intoxicants, including cannabis. In 1998, she joined the RAND Corporation as a research economist, where she spent the next 21 years working with colleagues in RAND Health and Drug Policy Research Center, evaluating state, federal, and international public health policies and law enforcement strategies targeting risky behaviors, mental health, and substance use disorders. And she is without a doubt one of, if not the leading expert in the area of cannabis and the regulatory space. So I'm going to turn the presentation over to Jess first. So welcome to our two esteemed presenters.
Thank you, Radonna. All right, I think this is going to work. All right, can you all see my screen? Awesome. Well, so grateful to everyone for joining us for the webinar today, and so excited that both Radana and Rosalie can join us too. This is the first of a three-part series because we have a lot of questions that we've been fielding from the field, from practitioners, from families and patients. So I think this is a really important series. In terms of topics I wanted to cover, giving an overview of prevalence, some of the health risks and health consequences, and just some high level sort of stage setting. And then I'm going to hand the Zoom mic over to Rosalie. So in terms of cannabis use and addiction prevalence and what we know with data, and also talking a little bit about the types of cannabis products that are out there, which is an ever increasing list of products and formulations and routes of administration. And then we'll dig into some more recent studies as well. So as you all know, there are, I feel like on a weekly basis, more cannabis products for us to track and be aware of, and a little bit more on the risks and health risks and consequences side too. So we still have very common cannabis products like the plant-based smoked cigarettes, blunts, available in pipes or water pipes. We also have vapes and the use of cannabis through electronic vapor devices. There's also reusable as well as disposable versions of those vape technologies available. There's also an ever-growing list of edibles. They can be mixed or infused into food, drinks, cookies, sodas, or alcohol and other drinks, as well as candies, gummies, and other items. There's also dabbing, which is the inhaling of oil concentrates and other extracts from the cannabis plant. And one thing to note that THC oils and concentrate used in vaping and dabbing often involve the use of very highly concentrated forms of THC, which may have harmful additives and be contaminated with other substances that could be harmful. We also know that how cannabis affects a person depends on many different factors, including the concentration of the THC that's used, and there's not always proper labeling or notification of that. The frequency of cannabis use, right? The use patterns can also be detrimental to health. The use of cannabis with other substances, whether that's alcohol or other drugs, the mode of use, right? The list that I just went through and some of these options here. For example, consuming edibles or products with higher THC concentrations can have a delayed or unpredictable effect on the individual. Previous experience with cannabis, your own biology, your genes, your DNA. There's some differences between sex. Women, for example, may experience more dizziness after using cannabis than men. And your age, with the more adverse effects we see for adolescents and young adults. Now, the other thing is we know that with some of the changing policy landscape, and Dr. Bakula will get into this, but in terms of the medical uses and the FDA approved medications, we have some synthetic forms of both THC and CBD that are available to treat different health conditions that are approved by the FDA. Dronabinol and abalone are made from a synthetic or lab-made chemical that mimics THC. And you can see here some of the health conditions that these are approved for: anorexia and weight loss for AIDS patients, nausea and vomiting associated with cancer treatment, and chemotherapy for treatment for chemotherapy-induced nausea. Epidiolex is actually FDA approved, but it's a purified form of CBD and has been approved to treat seizures associated with two very rare forms of epilepsy. One thing to note is that cannabis itself, particularly inhalation or these routes that we just went over, have not been FDA approved for any health condition or any indication, right? So there's a lot of, I think, confusion that happens out in communities about medical purposes, but we'll have an entire webinar associated with that. In terms of prevalence, right? How prevalent both use and cannabis use disorder are. The SAMHSA household survey from 2024 shows that among people 12 and older, past month use of marijuana increased from 37 million people in 2021 to 44.3 million people in 2024. So we have a pretty significant increase in past month cannabis use for 12 and older individuals in the US. Now, also of note is that 1 in 20 adolescents, about 1.6 million people, and about 1 in 4 young adults used marijuana in the past month. So we're starting to see a larger percentage in the 12 to 24 age range as well. I sort of highlighted there, so you have a little bit of comparison of the amount of people with past use marijuana compared to other substances. Now, there's also trends that are tracked in the household survey on past month adolescent marijuana use. So we have 6.4 million underage individuals, meaning individuals between 12 and 20 years old, reported past month marijuana use, according to DISDA. Now, that's past month use. When you look at the household survey and dig into cannabis use disorder or marijuana use disorder, we have 20.6 million individuals have a diagnosable marijuana use disorder. In terms of marijuana use disorder from this data, that equates to 20.6 million, so over 20 million Americans aged 12 and over, 1.2 million adolescents and 5.5 million young adults that have a past year marijuana use disorder. Now, I think that the thing that's of concern when you look at the household data is that when you look at severity levels, 1 out of 3 adolescents with a marijuana use disorder have a severe SUD. And that's a higher percentage compared to young adults and or compared to older adults when you look at either mild, moderate, or severe. So something to pay attention to, with also real gaps and barriers and questions about how do you get help for and find treatment for cannabis use disorder. In terms of how a marijuana use disorder is diagnosed, I always think that it's important to make sure that folks have access to this. And the household survey uses the criteria in the DSM-5. And here there's a study that was published by Case Western University that goes over the cannabis use disorder diagnostic criteria. This includes using more cannabis than you intended, a desire to cut down but not being able to, excessive time spent acquiring cannabis, using cannabis, or recovering from its effects, persistent cravings for marijuana or cannabis, cannabis use despite known consequences like neglect of social obligations or social or family problems, giving up important social, work, employment, or recreational activities, continued use despite physical harm or injuries, continued use despite physical or psychological problems, building a tolerance, meaning needing more cannabis for the same effects, and withdrawal symptoms when not using cannabis. Also from Case Western University, symptoms and consequences, but beyond the criteria for diagnosing a marijuana use disorder, reports of withdrawal-linked distress from sleep disturbances, irritability that sometimes makes cutting down hard. This is cited in research and from our patients as a barrier to quitting among individuals who are treatment seeking. And some of the most common features of withdrawal are anxiety, irritability, anger, disturbed sleeping, depression, changed mood, loss of appetite. There's also reports of a decreased sense of life satisfaction, some cognitive impairment, driving impairments, and linkage to poor educational outcomes, dropping out of school, lower grades, and lower IQ and testing on intelligence tests and scores. There's also a study that came out from JAMA Psychiatry that I think is important to pay attention to, and it sort of kind of backs up some of the numbers we're seeing from our national representative samples of marijuana use disorder prevalence, that 3 out of 10 people who use cannabis have a cannabis use disorder. And yet we have some Pretty alarming or concerning myths that circulate that you can't become addicted to marijuana or cannabis, that there's not no such thing as a marijuana use disorder, when there are millions of individuals here in the US who have a diagnosable marijuana use disorder and in many cases are seeking treatment and unable to be connected to that. Another 2017 report from the National Academies of Sciences, Engineering, and Medicine brought together clinicians and researchers in public health, oncology, hematology, pulmonary and critical care, psychiatry, pharmacology. The institutions were, I think it was Harvard, Johns Hopkins, Mass General, Columbia, Oregon Health Sciences, Vanderbilt, Penn Medical School. This is a big report. A lot of the data that was pulled together and released. Some of the main findings were that cannabis impairs the performance and domains of learning, memory, and attention, that use during adolescence is related to impairments in academic achievement, education, employment, income, and your relationships. And then also, and very alarmingly, that cannabis use increases the risk of developing schizophrenia and other psychoses. The higher the use, the greater the risk. Other piece to flag in terms of adolescent use, that the risk of developing cannabis use disorder is greater for adolescents, right, for people under the age of 18. This is a study out of the Department of Psychiatry at the University of Minnesota. A couple other things, I'm going to hand the Zoom mic over. But we know that adolescent exposure not only has some of the increased risk of developing a marijuana use disorder, increased cognitive impairments, but also that there is some findings in some of the studies, I think these are preclinical studies, about cross-sensitization to other substances as you get older, right? So there's a concern about sensitivity to other substance use disorders as you get older when you have earlier onset or earlier exposure to cannabis, alcohol, and tobacco. Now, in terms of other categories of higher risks, in addition to adolescents, we know that studies have shown that fetal exposure to cannabis is associated with negative outcomes related to fetal growth, low birth weight, and preterm delivery. You show that cannabis can reduce your sperm count and your concentration, change sperm motility and morphology, and change your hormone levels. The science in this space is pretty conclusive, and lots of different studies have been published, and yet not a lot of awareness among family, caregiver, and general community about some of these risk factors. And then a couple other items to flag. We saw this important study that was published by Dr. Volkoff that shows that cannabis and psychosis, or cannabis can increase the risk of both psychosis and schizophrenia. We also saw that in the NAS report. And then there's new studies that have came out just in the past couple months. Cannabis use has been linked to a higher risk of heart attack and heart disease. The study was published in the Journal of American College of Cardiology, found that those who use cannabis are 4 times more likely to experience a stroke, 3 times more likely to experience major adverse cardiovascular events, and twice as likely to experience heart failure. The study found that there is a 400% increase in stroke for individuals with using cannabis, a 300% increase in experience a major adverse cardiovascular event like a heart attack, and 200% increase in heart failure. Now, another study that came out showed that cannabis use is associated with an increase for suicide risk, even controlling for depression. So the large systematic review was published in Drug and Alcohol Dependence, and it shows that cannabis use was associated with an increased risk of suicidal ideation and suicide attempts, even when controlling for depression. And among adolescents, cannabis use was linked to a 1.85 time higher likelihood of attempting suicide. And for adults, the risk of suicidal thoughts was almost doubled. So again, that's a 185% increase in the change of attempting suicide for teens and a 200% increase in suicidal thoughts for adults. So some real important data coming out of our scientists and our research that show increased adverse effects and health consequences for cannabis use.
Thank you so much, Jessica. I'm going to be talking a little bit about some of the reasons why the research that Jessica gave an overview of might not be as well understood or adopted or considered by everyone. And that has a lot to do with the fact that we're talking about research that's happening in very different markets for these legal cannabis products. Different products are available, different places. So this is not as easy as studying it in the lab. In the lab, there are some very definitive science, and that's what the early 2017 National Academy of Science report really focused on. But people then want to say, well, you know, what else, what's happening in the real world? Because the real world is different. And that's a valid point. So I'm going to be, now I'm trying to get my slides to forward. Thank you. Talking a little bit about the world environment. So let's just take a step back. The US is not the only place that has legalized cannabis for adults, meaning some states, not all states. Here in this world map, which shows policies as of January in 2015, all the green countries are countries that have legalized recreational or adult use in some way, shape, or form, different types. And the blue countries are ones that have legalized medical cannabis. So this is an area of rapid policy evaluation in many parts of the world. And here's just a quick list of the various different types of countries that have legalized, and they're using very different models. So when we do comparisons with other countries, it's really difficult to say definitively if that comparison is apples to apples or apples to oranges because of the differences. The same is true in the United States. Here's a map of the state policies in the US, thanks to the National Conference of State Legislatures. It documents states that have legalized cannabis for adult use. That's that light green version of the states. States that only have comprehensive medical cannabis programs are in dark blue, or in blue, and you don't see any of those. And the reason why is because every state that has adopted a comprehensive medical program has eventually, as of June 2025, also adopted an adult use state policy. So that's an important factor we have to consider when we conduct research. There's several states, however, that have passed, instead of a comprehensive medical program that allows any types of cannabis to be used for medicinal purposes, there are restrictions in some states that say, yes, we're for medical cannabis. That's the light orange programs that say, look, we allow anything that has high levels of CBD, but not high levels of THC to be used for medical purposes. And that's consistent with some of the scientific literature that's been used to evaluate the effects of different cannabinoids inside the plant and their relative effectiveness on different diseases. So if you look at this map, you have a hodgepodge of different states doing different things. Only 2 states, Kansas and Idaho, that have not yet addressed this question of medical or legal adult use of cannabis. And that makes it very difficult to assess what the impact is of different policy environments on outcomes, because almost every single state has done something. And those somethings look pretty different across them. And I'll get into that in just a moment. I also want to highlight, though, that since 2018 Farm Bill in December, the federal government legalized industrial hemp, which they determined as any cannabis-based plant that has less than 0.3% delta-9 THC as measured in dry weight. That's a very important distinction, because in states, any state, now that it's legal, industrial hemp can be grown, and you can extract from the plant any cannabinoid, including THC, and generate products that have greater than 0.3% THC, because that requirement was only for the dried plant, not for the derivative products from it. So it's really difficult now to study the impacts of cannabis policies when you have a version of legalization operating even in places like Idaho and Kansas, or Indiana, which is generally one of the most conservative states in terms of cannabis policy. So there's lots of interest in understanding the impact of these policies. I can tell you the literature has been very clear so far, regardless of the complexities of studying this, that legalization has definitely increased the adults prevalent, whether we're talking about 30-day use or past year use of cannabis use. A little bit of an increase on frequency of use as well, and certainly daily use. In fact, one of the important insights today made by my colleague John Calkins, he has shown that since 2023, daily use of cannabis now exceeds that of daily use of alcohol use. So cannabis is the new alternative substance. And the question is, what levels are being used, which level, are people drinking the equivalent of a wine, something that's relatively low intoxicant, or are they drinking daily something that's a very hard whiskey or brandy? We know for alcohol, that's an important distinction. And yet in our literature, as I'll say momentarily, we don't know how to differentiate that because we aren't asking that level of detail in most surveys. And when you go to the hospital, the doctors don't know to ask that either. So that is a problem. We do know also that legalization and commercialization has also been leading to an increase in that cannabis use disorder, those trends that Jessica talked about. There's a lot of inconsistency in findings related to the impact of legalization on youth cannabis use, and many of us care. There was a big promotion that legalization was going to reduce access for youth. And the question is, has that actually occurred? Depending on the study, you can find the finding that you want. And it's not that the studies are trying to be biased, it's that the science is limited. Same with impaired driving, mostly because while we do see an increase in cannabis-involved impaired driving, we can't say definitively that the person who was in that crash or accident actually was under the influence of cannabis because it's retained in the body for so much longer. And our ways of measuring cannabis use in crashes are not as strong as, say, alcohol, where you have a breathalyzer. We're working on innovations in a few areas. They're being fielded, but the question is, definitively across all states, no, we don't know this. So the bottom line is it's really difficult to answer some of the most interesting questions that we're interested in. And that's because we have different ways of measuring cannabis use. There's different cannabis products. We don't know what they're doing. I'll go into a little bit more detail on that. There's different ways of representing the legal cannabis policies in these studies, and some are not as careful as they need to be in understanding the cannabis regulatory environment. And then finally, the methods and data that are being used aren't always ideal for drawing causal inferences, even if the individuals doing the study really want to lead that conclusion. Let me go into depth on the first 2 points. The third point, we could spend a whole day going into. So I'm going to start with the first two that are a little bit simpler. And that is measuring demand. Right now, most studies that try to evaluate this at a population level, I'm not talking necessarily at a clinical level where you have the ability to look at a wide range of saliva and blood and other aspects that you can measure. But in population level studies, we basically use measures of any lifetime use, any past year use, any past month use, or whether you're using it 20 or more times in the past month. And this doesn't tell us anything about quantity. If those of you are familiar with, your friends who drink alcohol, someone could be drinking a glass of wine with dinner nearly every night, and no one would consider them an alcoholic or having a problem. So we need to know more. These prevalence rates represent a composite of different things. You have occasional users that generally use less and not using in harmful doses. So it's unclear if these population level studies, usually household studies, which overrepresent these occasional users, are the right population group to ask questions. Do we care? Do we care so much that people are enjoying casual and harmless use? Probably not. We probably want to know what populations are at risk of harmful use. To do that, some people look at more regular consumers and people who are believed to be using higher amounts, usually self-identified, or we look at near daily users. This has been a real problem when thinking about cannabis, because if you are a patient using cannabis as your medicine, daily use is usually your regimen. It's not an indication of harmful use. But that's different if you are an adolescent vaping who is using their vaping pen every day because it calms their anxiety and it's not medically supervised by a doctor. So the prevalence of different types of users in different studies varies significantly, and people need to be paying careful attention to these different populations represented in the study when they evaluate. But more importantly, they need to pay attention to how much is being consumed and what's the mode of administration. Even with a cannabis plant, we know in the US, and I'll show you statistics in just a moment, that most of the users in the US are using cannabis plant material. But today in California, particularly, I just saw data on this, so I'm particularly excited about it in terms of information. We sell more in terms of pre-rolls than we do of cannabis bud flower or bags. And that's important because pre-rolls of cannabis can actually be infused with higher potency THC concentrate and the like. The natural cannabis plant generally doesn't have more than 30% THC on average in most countries. It's typically below that. That's not true when you cultivate towards THC, and I'll get to that in a moment. But the cannabis plant itself is relatively low amounts of delta-9 THC naturally occurring. The problem is that we have also for sale, and with very little limitations in the US, cannabis-infused products, vaping oils, vape pens, dab, concentrates, and the like that have much higher THC concentrations. And if you're using these products and not moderating the amounts, so say, a vape cartridge has it has only 10 milligrams of THC in a single hit. The question is, how many hits are you taking? And are you taking a full hit or a half hit? These are questions we're actually examining in the labs right now to get at the answer of it to this. But there's also all these other hemp-derived products that now are legal and sold elsewhere. They're in beverages, they're in brownies, all sorts of different products. Some of them are natural cannabinoids and some of them are synthetic. And we don't know how to measure this and to know the impact and how much is being used. And then there's this question of all the other extracts that could be made or derived from the cannabis plant. So this is not an easy question. And a chemist can tell you lots of details about this. But let me just take a step back and say, we have failed to consider not just level amount used and metrics of use, but also the variation that exists across the world and in the US in how these markets are operating. I like to show this slide because it gives a sense of just a few elements. It's not all areas of market regulation, but a few key elements that differ. In Uruguay, which was the first country to legalize, Canada, which legalized in 2018, and then 2 legalized states in the US. California legalized a little bit later, but was one of the first to adopt medical cannabis, and Connecticut, which legalized fairly recently. What's important to notice is that there's differences in the type of products that are allowed to be sold in each of these examples and the average potency or delta-9 THC in the product that could be sold. Uruguay, when it legalized, only allows flower to be sold in pharmacies. That's the only place you can buy cannabis. And you have to register with the country to buy in a pharmacy, or you can instead be part of a cannabis consumption club, or you can instead register with a country to home cultivate. You cannot use all three. You have to predetermine which one you're going to do. If you're going to buy from the pharmacy, what was the only cannabis available in Uruguay was 9% THC. It got increased in about I want to say it was like 2017, maybe it was a little bit later, to 15%. And just this year, they now offer strains in the pharmacy that are just below 20% THC. It's a moderate amount of THC that can be sold in the cannabis product plant in Uruguay. They haven't seen much of an impact on cannabis use disorder in Uruguay. Canada also had a very interesting rollout of its policy because when it first legalized in 2018, it only allowed the flower product to be sold for the first 18 months because it was really struggling with do we allow these other products and can we cap the potency in them given we're concerned about excess exposure of THC. In January 2020, federally, they decided, okay, the provinces get to decide which products get to be sold and we will let them experiment. 2 provinces in Canada do not allow edibles or concentrates, and that's Quebec and St. George Island. So those 2 provinces do not allow any other products to be sold, only flower content. There's one exception in Quebec. You can get dried cauliflower and broccoli with THC if you really want an edible, but that's the only edible allowed. The average potency of the THC flower sold in Canada is between 20 and 25% THC, delta-9 THC. They allow for home cultivation as an alternative. You don't have to register, but any package of cannabis sold in Canada has a single serving in Canada, a single serving dose of cannabis is typically around 5 milligrams THC, 1 milligram, 2 gram, a package, like a package of cookies or a package of brownies or whatever, can't have more than 10 milligrams THC total. In the US, that's typical serving size. And that's all that's allowed in Canada in an entire package. So when we talk about comparing sales data or use measures, the norms in Canada for using cannabis are fundamentally different than what they are in the US because what products are sold look very different. In the US, I'm going to just give you a quick comparison of California to Connecticut. In California, my colleagues at RAND, analysis led by Rosanna Smart, Bo Kilmer, John Calkins, and Ziba Cooper from UCLA, they were examining California seed to sale data. And they assessed in California in the last year, the modal THC cannabis product purchased in California had 30% THC of the plant. That is much higher than what we see in Canada, in Uruguay, in the Netherlands, in Israel, in any of the other countries. And that's different than Connecticut, which capped its flower products, can't have more than 30% THC total. So the markets for these two products in California versus US, just flower product, are different. You're not getting the same milk when you go to the store to buy milk if you're going in California versus Connecticut. And California allows cannabis buyer clubs, home cultivation, doesn't cap concentrates in any way, shape, or form in their potency. Whereas Connecticut says, nope, no cannabis buyer clubs. Yes, you can have home cultivation, but we're going to cap the concentration of vape products and concentrates to 60% THC, not allowing anything else to be sold in our stores unless it's and this was an industry supportive policy, unless it's a pre-filled vape cartridge, because the industry didn't want to have to make separate cartridges just for Connecticut. That makes it difficult for business. So these are some important distinctions that exist across the states. How do you then compare legalization in one state versus another and try to identify the impacts of legalization? And the answer is you have to pay attention to these level of details. You have to consider them. And so with a group of colleagues, Tim Namey, Rosanna Smart, Jason Blanchette, Marlena Lira, and Annie Busted, we started looking across all 50 states. Based off of advice from experts, we define what sort of regulations might matter if we're worried about excess adult use, not any adult use. Any adult use doesn't matter. Excess use that might be harmful to your health, that's what we were concerned about. Youth use, and then any impaired driving. We came up with a list of 18 different regulatory areas known to be significant both for alcohol and tobacco that needed to be considered for cannabis. So we tracked this across all 50 states going back to 1999, going forward to 2019. And then we looked at this cannabis policy scale that is a collapse of all those 18 policy areas. Higher scores mean more restrictive, lower scores mean less restrictive. That cannabis policy score includes states that lower penalties, so decriminalized states that might have just lowered penalties but not legalized use. That's part of our cannabis policy scale that I'm showing you here in green. Decriminalization, which can happen in some states, which is just a reduction in the penalties associated with small amounts of possession of cannabis up to an ounce. That's not legal sale, that's just possession. Those are the red states. Blue states are prohibition states. And then green states represent all these different areas of regulation that are either medical or adult use. And we're, again, assessing what's the likelihood that they expand the market or lead to excessive use. And if you look at our cannabis policy scale, which is capturing these 18 different regulatory areas, back in 2005, before the Ogden memo, which was a federal memo that basically allowed states, told the states, look, you guys go ahead. If you're following your own state regulations, the federal government is not going to interfere. Before that Ogden memo in 2008, states didn't look all that different in terms of their restrictiveness, even in medical states. And this is this policy scale, our green policy scale. This is showing you the quintile, the interquartile distribution of the value of the cannabis policy scale for the states in 2005. And there, it's a little bit less regulated than decrim and prohibition, but these not very big differences across the states. If you look at 2012, which is 8 years later, on the cusp of legalization in Oregon or in Washington State and Colorado, you see states, and this is post-Ogden memo, you see states starting to vary significantly in their range of legalization. Some states are very restrictive in medical cannabis, very, very restrictive, look just like decrim states, but they have medical cannabis. And other ones look really a little bit liberal. They're as far down as 70% less restrictive than prohibitive states. So this is really a big difference in terms of states. Now, if you're comparing states that have medicalized in this period, and you're comparing all medicalized states to decrim or prohibited states, it really depends which states you're looking at as to whether or not you're going to see an effect or not. And people weren't paying attention to that. Then you add legalization to the mix, and you see our cannabis policy scale in legal adult use states looks very different, very wide variation, some of which still look like, they're more liberal than they were in 2012 for legal adult, and the medicalized group looks like they're much more specific. So trying to analyze the effect of these evolving cannabis policy without thinking about the level of regulation and which regulations are really mattering is not going to give us the answers that we really want to know for some of these difficult questions like youth use. Because for youth use, it's not just a question of whether or not it's legalized or not. It's a matter of whether or not they see stores when they go to school and whether they're getting advertisements promoted to them. And whether or not they're seeing adults around them using. And we have regulations that influence all of those things. So some might get exposed, some might not be exposed. So the bottom line is we need to be paying more attention to the types of regulations that states are adopting. And there's three key regulatory areas that we're paying attention to that we think are particularly important. The first is product regulation. Which products are people using? And that's really hard to answer because we can only observe it when people self-report it or we have store data. So what I'm showing you here is data from the International Cannabis Policy Study that was reported as part of the updated 2024 National Academy of Science study of the impacts of cannabis legalization. And what it suggests is in the household population, again, households, 70% of the household population in our most recent year of data reported to the committee used dried flower, 50% used edible, and about 42% used vaping oil products. Okay, so vaping has stabilized. Edibles seems to have been rising. Drinks, concentrates are also rising. Dried flower seems to be declining, and this is among the household population. But studies are also being done by the industry. And what I'm showing you here in this bar graph is what the industry reported. This is MJ Biz Daily report of a study that was done by the cannabis industry that we don't know the sample of. But this is a different range of products that were purchased according to stores. We don't know which stores or what states. We have about 52% of people saying they didn't purchase any cannabis. But if you look at the industry data, it looks like, and they look at it by THC type, or CBD type, which is important for them to know what sort of products to produce. But they only have 48% of their sales or their market being flower material. They have 26% being edibles and 22% vapes. So if you look at the market according to the industry, vapes and edibles, which have higher concentration than the cannabis plant of THC, are generally more available and sold more than what we hear in the household population. Again, a difference in population. I'm not saying one is right. I'm just saying that they're different populations here, but it's important to understand, particularly when we think about health effects, because the health effects we believe are likely to be tied to two things, either the level of THC that can create an intoxication effect. That's one way it could be harmful, but also then all the other ingredients that individuals might have possible reactions to or problems with, either because of being young, developing brain, other medications that make you susceptible, or age or other physiological effects. Okay, so the first was product regulation. Second area of concern is marketing and promotion. And again, from MJ Biz Daily, this is an industry report. I mean, they clearly say beyond THC levels, that's a marketing tool for these products, is the THC level. Branding, packaging, and promotions, we know heavily influence consumer choices. So we don't need scientists to study it. We actually have the industry acknowledging it. But in our 2024 National Academy of Sciences report, and I say our because I was a committee member, we noted that while there's states that have regulations against some of the branding and packaging, no child enticing products. Jessica already showed you pictures of very child intoxicating products with Sour Patch vape pens and the like. there's lots of states that are violating these regulations. So an important part of this regulatory structure is not just whether or not states have laws on the book, but how actively are they enforcing against marketing and promotion of the cannabis products. How important is marketing and promotion? Well, I already told you the industry knows it's important to them. But I was part of a study led by Kevin Lin at Harvard University, who was doing his doctoral research, where we looked at cannabis related emergency department episodes across the US using claims-based data. On April 20th, 420, the official, not just US cannabis holiday, but worldwide cannabis holiday, promoted for a way to try to change cannabis laws and advocate for a use, any use. And we compared ED visits on April 20th to emergency department visits exactly 1 week before the day. So same day of the week, regardless of year. It was always the same day of the week, 1 week before and 1 week after. And what our research showed was that on 420, there was a 17% higher rate of cannabis involved ED admissions than on a week before or a week after. And we can't say definitively whether this is promotion and marketing versus maybe just social, everybody is out enjoying it. It's just like New Year's Eve or something. But what I can tell you is in the analysis of the California seed to sale data that Rosanna Smart, Bo Kilmer, and others analyzed, they showed on 420 that that day specifically, there was over a 30% decrease in the price of cannabis being sold than 1 week before. The whole week before, prices were only 2% lower than average. On 420, prices were 30% below average. So there's a promotion effect of cannabis use on this holiday that seems to be associated with acute harm because of presumably excess use. Not everybody, but excess use. So the final area of regulation is this question of retailer exposure. And there's been actually more research being done on this topic. As I'm showing you here on the map, again, this is a graph from our National Academy report. There's huge variation in exposure to cannabis outlets. And that has differential effects, not just because you might be in, you see a Starbucks, you want to go to a Starbucks. It's not just that. It's the fact that different states have rules on how you can advertise with those stores. Some can be outward facing so that the promotion can be seen by anybody walking by. Some only say interior focusing. And we need to understand, does that matter in terms of increasing use? And so what do we know from this? I mean, how important are retail stores? If people are going to the illicit market, the retail stores shouldn't matter. I've heard people tell me. So again, we went back to the International Cannabis Policy Study and asked, where are people buying their cannabis? Because if people are only going to the illicit market because it's cheaper, then it doesn't matter what we do with stores. It turns out, overall in the US, the share of people reporting buying from stores is now greater than any other source. Dealers, the illicit market, is down to a quarter of people responding, about 50%. 6% say they buy from stores, but that's overall. And we have different policies across the states. So when you look at it by legalized states, we now have 2/3 of people in legalized states saying they're buying from a legal dispensary store. Yes, some people still in these legal states are buying from the illicit market. That's this dealer column here. We see that 23% are buying from a dealer when they live in a state that is a legal store, but it's not as significant as some people have conveyed. We have the vast majority of consumers purchasing in legal stores. So my main takeaway, so we allow a little time for questions, is that there's clear evidence that cannabis legalization has led to an adult increase in prevalence rate and in cannabis use disorder, both among adults as well as youth. Impacts on youth or overall harms because of relationship with alcohol or other things are still being evaluated. And the early studies are not the definitive answer because of issues with data and not considering these differences in cannabis regulation. There's a lot of uncertainty in the literature that has been, now people are aware of because of this diffusion of new products. Canada doesn't have hemp problem. They legalized federally. People don't consume hemp-derived products. In Canada, hemp's still used for industrial products and other things. And so this difference is a uniquely US factor that we have to really kind of consider and understand, and we aren't measuring it well right now. So those are some of the difficulties in trying to understand the impacts of these policies on some of the key questions that we care about. I'll stop there.
Hey, great. Thank you all. I just wanted to say that we had over 1,000 people register for this webinar showing the importance. And as I've been checking the number of participants, at one point we had over 600 people that are participating. So there is a lot of interest. We solicited some questions in advance, and then there's some questions that have come into the Q&A. So I'm going to throw a few out to our presenters. The first thing I'm going to start with is a question to Jess. Jess, there was a whole bucket sort of questions, and I think in subsequent webinars we'll drill down a little bit more, but can you speak a little bit more about harms related to adolescent use, both in terms of neurodevelopment, as well as social development and potential. It was referred to years ago as a gateway. You used different terminology, kind of the priming effect that cannabis can have, or any addictive substance for that matter, if it's used during a critical period of brain development.
Yeah, absolutely. Um, I think that we've learned so much over the last like 30 years just about adolescent brain development and the risks associated with different substance use. So that, and even in Dr. Pakula went over some of the changing laws in different countries as well as in the US. But in no place are we legalizing cannabis products for 12 to 16 or 12 to 18-year-olds. And that increased risk, increased use of cannabis among that age group does really have specific risk factors because of the adolescent brain. Adolescent brain is, a kind of an amazing machine. You can learn more quickly. You can learn new skills more quickly. It's still sort of developing, but it can also be harmed more easily than an adult brain. So I think that we really need to understand and look at the risks for adolescents separate from adult populations because those risks are unique. There's higher risks for educational outcomes, cognitive impairments, your IQ and sort of learning attainment, social pieces that go with it. But then, as you mentioned, Radonna, we used to talk about the gateway theory, that these are gateway drugs. But now we know that there's cross sensitization, which I think is actually a little bit more scary, right? If you are priming your brain in middle or high school because of THC or cannabis use or combined alcohol THC use to be more sensitive to addiction for the rest of your life, I think that's something that we need to make sure we're letting adolescents themselves, parents, caregivers, pediatricians, healthcare providers, and everyone know about. I also think that there's some alarming data about, particularly if you have addiction in your family history, so if you have a genetic predisposition, you're going to have higher risk factors. If you have mental illness in your family, you might have higher risk factors for, let's say, cannabis-induced schizophrenia or other sort of mental health adverse effects that could come from this. So I think we have to be aware of our unique risk factors, be aware of unique risks if you are an adolescent or a younger adult, because it's not legal for individuals under the age of 21 for a reason. And I think we need a lot more research and study about how to implement prevention efforts, particularly in states that are changing their laws so that we can more effectively reduce cannabis use disorder and reduce sort of adverse effects among young adults. It's one of the things that sort of keeps me up at night. And the other thing, if I could just talk for 1 second about binge use, we have sort of, and when it comes to alcohol and alcohol use disorder, we know that it's not good to binge drink. We have an idea of how many drinks that is appropriate, and we have some social norms and some harm reduction that's built into sort of the fabric of how we sort of socially consume alcohol. What about 60% of adults in America consume alcohol products, and there's some guardrails that we have socially on how you do so safely. What are some of these? We can say it together. Don't drink before 5 p.m. Don't drink alone. Don't drink and drive. Maybe don't drink every day. There's even there's guidelines on how many drinks per week to have if you're a woman versus a female versus a male. And I don't think we have those guardrails or those, and also not initiating use before certain ages, whether that's 21 or that changes. And I don't think we have those same guardrails when it comes to cannabis use. So we see, in essence, binge cannabis use among age groups and individuals that have risk factors that shouldn't be consuming cannabis to begin with. And I think that's where we have some real risk factors for some significant health consequences for younger individuals.
Thanks, Jess. I will also say that the National Institute on Drug Abuse has been funding this longitudinal study called the ABCD study, where they started when kids were 11, enrolling them before adolescence and before they thought they would be exposed to any type of addictive substance, including cannabis, and they're following them to see what types of consequences result. And if people are interested, we might do a follow-up webinar and have someone from that study come and talk, because they do have a lot of findings now about a lot of different areas, including the use of mobile devices and time spent on mobile devices and the impact that has socially, but also on brain development. So, Rosalie, there were a lot of questions in the area of potency, and you spoke to that a little bit, but so talk a little bit more, riff a little bit more on potency. But one really interesting question that someone had to do with, okay, so what's the potency of products that are sold today in the United States compared to like marijuana that used to be smoked in the 60s,
Yeah.
because there's been a lot of discussion about increased of THC, which
Yes.
is that mind-altering, addictive sort of part of marijuana, and about increasing potency. Well, so can you say a little bit more about what can be
Sure.
purchased legally now and potency versus what you used to get and you bought from the illicit market
Yeah.
years ago?
So we did a really careful analysis of, and others have done similar, showing that cannabis seized by the DEA and other law enforcement agencies back in the 1990s had average potencies of 5 or 7% THC. That it was that low. And that was in the beginning of medical markets. They started rising a little bit, up around 10% THC. They got as high as about 17% THC in 2018, 2019, right when the stores started opening for legal cannabis. And now, as I mentioned, the range and potency of the plant. This is all plant-based THC. It's been cultivized and grown to enhance the number of buds and the amount of THC in the buds and the like. We're a very innovative country. We can do lots of things with our agriculture. So there now today, like I said, the typical plant doesn't usually have more than 25, 30% THC is high. In California, you can see it a little higher. Hopefully those won't spread to the entire market. But again, this is just the plant-based material. So when we talk about the effects, the health effects of smoking cannabis, a lot of the scientifically analyzed health effects is using cannabis that is that lower level THC, because that was all we knew. That's the federal government's allowance of that type of cannabis to be used for research purposes. And that was down between 5 up to maybe 12% THC. Radonna, you know better than me if they even have that higher level THC available for scientific research for NIH funded work. But a lot of researchers now are using state funds to try to evaluate products sold in the stores, because the biggest problem is we know nothing about the products being sold in stores today. Their potencies are substantially larger, not just flour, the concentrates. Edibles, pretty fixed. Edibles, you have 10 milligrams per serving. But what we don't know, are people eating a whole cookie, which was really 4 servings, so taking 40 milligrams of THC, or are they only taking a quarter of the cookie? So edibles are hard to study. Vapes and concentrates are easier. We're trying to get a handle on that. But their exposure to THC today is significantly larger. And I think that's why we're seeing this increased transition to cannabis use disorder among cannabis users. It used to be much, much fewer cannabis users ever got cannabis use disorder. It was below 10%. It was one of the least harmful substances out there. Today, that's not the case. And that's partly because of the rising THC in the products that people are consuming.
Yeah, so there have also been a lot of questions about adolescent use and legalization to adolescents. So I want to repeat again and make sure that we're all three sending the same message. There are no states that currently allow for the legal use of cannabis products, and the legal market does not include the sale or use by adolescents.
2 exceptions. One,
Okay.
medical market. So the medical market has a lower age in which you can purchase, 18 years or older. Any of the legal adult states in the US, it's 21 and older. And if you're a medical patient, your parent can allow a youth to use, but it's the parent that has to buy. No one under the age of 18 is allowed to purchase, even in a medical market, because as a youth, you have to have supervision. I think the second point to make there is that there's variation in the states and how these laws are being implemented. So we know from smoking, the federal government had to intervene with something called the Sinar Amendment and require compliance checks at stores that sold tobacco with minors who were either just below or just above, to see if they could actually purchase tobacco. There are very few states that actually do this in the US today. Washington State is one of them. And I am part of a study that's showing right now that within Washington states, it's not homogeneous across the whole state. It's associated with where they saw some problems and potential problems with sales to minors. When there's more compliance checks in an area, we see lower rates of youth use. And those lower rates are pretty much close to what the original, the areas that don't allow sales. So this issue of access by youth is a really important one. It appears, and we have a part of a different study in California, it appears that if we really are effective at checking compliance, we can reduce those sales to minors really effectively. And it is similar to being in a prohibited area. The problem is not all jurisdictions fund it, the compliance checks, they don't all do it. And so there's variation. And then there's also the problem that we all know, even in the case of alcohol, youth can get a fake ID.
So, Rosalie, there have also been questions that are state specific. So, if somebody wants to go and look up a state specific regulation to see what's the potency or different things that you've talked about today, are there a couple of good resources that you would offer to them? Or if you have to go state by state, where do you go? Like, where can people go to look at some of this thing for themselves?
Yeah, so actually in several talks with various foundations and agencies that are very, very interested in understanding how do states compare in this. We've gone state by state and to the state agency that's responsible for overseeing the products that are sold. Some states put their seed to sale data up on the web so you can see which products are being purchased and what's the testing THC level on average for that state. California is an example of a state that does that. It's not consistent across states. So it is one of those issues that is we need better data. That's one of the better data issues. I encourage people to go to the state agency that's responsible for regulating products sold, not retail licenses, products sold. Sometimes it's the same agency. Sometimes it's the Department of Agriculture. Sometimes it's the Department of Public Health. It's not necessarily the licensing agency. Sometimes they have that information. States like Massachusetts, where they have a relatively small number of people who are allowed to sell in a given area, have much better data because it's easier to stay on top of a smaller number of distributors than states like California, where it's very difficult because we have so many. And we also have a lot of illicit ones. And that's why they put out the seed to sale data, because that's the best we can do.
So I'm wondering, you developed that index that had all of these different categories, and you talked about regulatory environments that would be able to, well, let me just ask the question. If you were designing something from scratch today,
Yeah.
and you were going to try to create a regulatory environment to minimize risks to adults, because we're just saying no to adolescents entirely.
Yeah.
What do you think are the most important regulatory components to include, and what would those look like based on your knowledge, based on your looking at not only the United States, but looking at other countries as well?
Great question. I actually engaged in this exercise very recently in Germany. And fortunately, Switzerland is in the process of doing a pilot study where they're implementing in Switzerland, in the different cantons, variations of the key things that we said we should focus on. And so we'll have real data to know if my prior hypothesis is actually true or not. So this is me just conjecturing right now, based off what we've seen in Canada and their provincial differences, in the US, and what we know with alcohol and tobacco. If you legalize and you cap the potency of products that can be sold by commercial entities, what you are doing is then restricting the extent to which businesses can compete on higher THC type products. And we know, as I showed in the slideshow, that the industry does pay attention. They appeal, oh, you can get a better hit here. This is a big bang. If you allow home cultivation as well, then what you enable is, if a consumer doesn't like what's being offered in the store, they can go home and they can bake up whatever they want. That's consumer choice. There's no problem with that. Many some of the cannabis buyer clubs or social clubs, cannabis social clubs, do allow for these different products, but you can only use them on site and as a member. So there's no commercialization towards youth. That's kind of this how do we reconcile allowing adults to do what adults want to do, should have the freedom to do, but do it in a way that reduces the harm to youth? So the first is, we don't need super high potency products to be sold in retail stores. If people want to produce them at home or in their little specialty club, that's fine, as long as they're not out there in the public being sold or targeted internet. Adults are being adults. It's not a big problem. The second one, I think that's also really important, is requiring that any product sold in the retail stores be checked and known before it's allowed to be sold. Why is that important? Because adults care about what they're putting in their bodies too. They don't want any of these negative additives or potentially harmful additions. One of the things that might not be familiar to the audience is things like flavorings that we have been infusing in vape pens and nicotine devices are actually being cut out of those nicotine products, because when inhaled directly into the lungs, they're quite harmful, even if we can ingest them safely. And it's because of the mode of administration. None of that is happening right now in cannabis, and it needs to be considered. If we already know this for tobacco, why aren't we doing it for cannabis? It seems crazy. Why not borrow from the science? And so those things I think are really important for discouraging kids' youth, because cannabis doesn't smell very good. And cannabis flavored products aren't necessarily what kids are going to be enticed to. And you don't risk a child picking up a gummy that's sitting on the coffee table and putting it in their mouth if it doesn't look like one of their other gummies that they get to eat out of a little snack packet. So those sort of requirements of products to be sold can be managed much better if they are managed before they get on the market than post-market review. This is a big issue in the US. It's come up a few times. We haven't passed it. Germany was considering it very, very carefully. We'll see what Switzerland decides to do based off of its experiments. And then the third, and this is the hardest for the US, is our marketing and commercialization. We can't control anything once we legalize it because then we have freedom of speech, right? And the freedom to market. And it's very, very difficult then to rein in false advertisements, false health benefits, or unsubstantiated health benefits. And I have this conversation all the time that just because an industry said that and it's not just cannabis, just because an industry says this is good for you, that's good for their sales. That doesn't mean we know it's good for you yet. And we've seen this problem with pharmaceutical drugs. We've seen it with over-the-counter drugs. It's a common problem. It's less of a problem in other countries where promotion and branding and marketing can be much more highly restrictive. In fact, Australia has very, very bland product labeling. They have information, but it's all plain labeling, plain packaging. Canada, same. Their rules on promotion are much, much more restrictive. And yet we are still seeing some harmful effects in terms of cannabis ED visits or cannabis use disorder and schizophrenia. There's a recent study on schizophrenia as well, but it's much lower rates. They're still seeing an impact of these products, but it's at much, much lower rates and much smaller population risk. So those are the three things that I emphasize when I think of designing this from scratch.
Right, great, thanks. Jess, there have been a few questions about with the new regulatory landscape shifting so much and allowing for recreational use for adults of cannabis products as well as medical use around people who are in the justice population, people who are in a drug court or under supervision in the community. I know that you're also really involved in a large research network that's funded by NIDA that focuses specifically on justice settings. So just sort of what are you aware of that's happening, or what are we learning, or what do we know about what's going on across the country in that space of individuals under some kind of criminal justice supervision, and what's happening, and if they are allowed to use recreationally, if they are allowed to use for some type of medical condition, and what's your sense about what's happening there?
That's a great question. And I probably need to do a little bit more research on sort of variations between different states. The individual, because this is still not legal federally, there can be a lot of systems that are going to prohibit any use of cannabis or marijuana products if you are on criminal justice supervision. So for anyone who is in that category and is under supervision, making sure you're very clear on the requirements that are conditions of your parole or probation is very important. And also seeking support if you need treatments to comply with that requirement is really important. And I think that we're making progress on how to treat polysubstance use disorder and how to treat marijuana use disorder, but making sure that that's something you can discuss with the folks that are in charge of your supervision requirements, because there is a lot of variation, and by and large, it's still going to be a prohibited activity in the condition of your release or your supervision details. And I think sometimes folks assume that, well, it's legal in my state, so this is an activity I can participate in. But if your drug court or your probation department has federal funds that is being used for some of these programs, it can really vary. So I don't know if Rosalie has more information than I do here, but I do think you have to make yourself aware, not make assumptions, be very clear about the requirements of your supervised release or your probation or parole, and also ask for help, because there is such a thing as marijuana use disorder, and it is very difficult for patients, and finding qualified providers, having treatment to support you can make all the difference. And so I think we need to make sure we connect people with care instead of just having a punitive approach.
Yeah, I agree. I think the hardest part of those is that, patients aren't feeling comfortable discussing it with their doctors regularly. And that is a real problem, because if the doctor is not fully aware that the patient is using it maybe to calm their anxiety or some other issue, there can be real interactions with some of the other pharmaceutical drugs that the doctor is prescribing. And so trying to normalize this within the health area is really, really an important thing, not just for the criminal justice involved, but for everyone.